Hello, everyone, and thank you for joining our webinar today with Professor Stephen Hinshaw. Professor Hinshaw is a professor of psychology at the University of California at Berkeley and professor of psychiatry at the University of California, San Francisco. He is an international presence in clinical psychology and mental health, having authored over 320 articles or chapters and 12 books. Hinshaw received his Bachelor of Arts from Harvard University and his doctorate in clinical psychology from University of California in Los Angeles. Overall, he was one of the 10 most productive scholars in the entire field of clinical psychology across the past decade. His newest book, Another Kind of Madness, chronicles his father's recurring mental illness and the doctor-enforced silence surrounding it, plus the huge need to combat stigma. Today, Dr. Hinshaw will discuss the evidence and reasons for the continuing stigma of mental illness that exists despite the growth of public knowledge of mental illness. He will also share his experience growing up with his father's bipolar disorder, which was highly stigmatized, and the doctor-ordered family silence surrounding the issue. Welcome, Professor Hinshaw. It's a pleasure to have you with us.
Thank you so much. And welcome. The title slide, I believe, is up and running, so let's get started. I'll advance. So what is stigma literally? It's a Greek term. Many psychological and psychiatric terms are Greek. Back in Athens, if you went to the agora, the marketplace, remember agoraphobia literally is fear of the marketplace, it might have been important in that society to figure out down at the agora who had been fighting for Sparta rather than Athens, who was a former slave. So to take the mystery out of any social encounter, individuals in such groups had a brand burned into their skin that was visible. So that's what a stigma literally is a burned mark signifying low social status. In recent decades, 20th and 21st century, most stigmas are inferred. They're psychological rather than actual burn marks, although Hitler did brand with numbers people in concentration camps who included not only Jewish individuals but gay and lesbian people and those with mental disorders and mental defectiveness, so-called intellectual disability as it was known back in the time. Some nations branded HIV-positive individuals in the 1980s and 90s, but for the most part today, stigma is inferred from your group status rather than being a visible mark. Which groups are stigmatized, as it says at the bottom of the slide here? Many different societal groups. What's interesting and, of course, positive is that things can change over time. Not that many decades ago, being left-handed was a pretty big stigma. Today, being left-handed is maybe cool. You're one of the 11%. You have good spatial abilities. You go to MIT, but it was pretty harshly castigated even as late as the middle of the 20th century, meaning that societies and their values can change. Attitudes toward gay marriage have radically improved in the last 15 years in our country. But the bottom three today, if you look at evidence, people who have mental illnesses, people who don't have a home, people who admit to using and abusing substances are the least liked, the most stigmatized, and we'll talk more about the reasons for this. I wrote a book on this topic 10 years ago from Oxford Press, The Mark of Shame. The artist I chose for the cover painting is Hieronymus Bosch, the phantasmagoric Flemish painter from the 15th century. This is a painting of his called The Extraction of the Stone of Madness from 1496. It hangs in the Prado Museum in Madrid. And just a moment on it, we can see that the surgeon, but the surgeon's wearing a wizard hat, so we know there's some issues already, is cutting a hole into the patient's skull and allegedly removing the stone or the rock that was held to be the cause of mental illness back in the early Renaissance in Holland. The priest with the chalice is giving a blessing. The poor patient is giving direct eye contact to us. But if you look closely, it doesn't seem that a rock or stone is emerging from the patient's head. If you see the little white kind of tufts, Bosch was actually painting, if you read up on this, that the surgeon wizard was extracting a flower from the patient's head. What was the name for mental illness in Holland at that time? You were called a tulip head. Tulips were a valuable commodity, but if the tulip got inside your head, it made you a, quote, lunatic. So in funny ways, Bosch was painting that if the surgeon removed the name, the label, the diagnosis, maybe the patient would be cured, which is very modern in its implications. Are psychiatric diagnoses like bipolar disorder liberating, give you a reason for treatment, stop blaming yourself, or are they harsh social labels that mask social ills? So in many ways, this painting from hundreds of years ago is quite modern. That's why I chose it for the cover of The Mark of Shame. Moving forward, there's been a big change in the last 65, 70 years in the way scientists think about stigma and prejudice. In 1950, a bunch of Berkeley sociologists and psychologists wrote a book called The Authoritarian Personality, which was really based on the premise of trying to figure out why so many German citizens supported the Nazis back in the 30s and 40s. And the idea was that there's a subgroup of people with harsh repressive parents who develop defense mechanisms and become prejudicial or become bigots. Today, the attitude of social psychologists and the belief is quite different. Most people, under certain circumstances, actually show stigma towards people in outgroups because of, going down the slide here, all of us have to stereotype just to negotiate social interactions in a given day. Hard for me to meet you without seeing if you have gray hair like I do, or maybe younger, wear glasses or not, or male or female. Stereotypes help us categorize, but if we start to dislike members of groups that we stereotype, now we're showing prejudice, we're getting emotion in here, and we may hold in lower regard certain subgroups. Maybe then, if I'm a member of the majority group, I start to discriminate and take away the rights of people in some of these lower subgroups or lower castes, if you think of the caste system in India and other cultures. So stigma starts with stereotypes, which are kind of normal social cognitions, progress to prejudice and discrimination. But if I stigmatize you because of the group of which you're a member, everything about you relates to that group membership. It's a very global process. Your individuality is lost. And think again of stereotypes, prejudice, and discrimination against people with schizophrenia, bipolar disorder, PTSD, autism, ADHD. The very labels bring up an image that everything about the person is because of their psychiatric illness. How do we know that people with mental disorders are stigmatized? Well, we've done a bunch of attitude surveys for the past 60, 70 years, and consistently both the specific labels and diagnoses of mental illness and the general term receive very low social regard and high social distance. We don't want to spend much time close with such individuals. Susan Fiske, the noted social neuroscientist at Princeton, has tried to explain such phenomena by saying that when we perceive people in other groups, we judge them on two dimensions. One is how warm or cold they are, and another is how skilled or incompetent they are. And too often, people with mental illness and homelessness, etc., fill that kind of cell of not very warm, not very competent. And Fiske refers to this as the lowest of the low, the humans that we don't want to spend much time with. In fact, in brain scanners, when people confront images of people with low warmth and competence, including the stereotypes of mental illnesses, One of the first brain regions that lights up is the insula, which is where disgust registers. So this isn't even mediated by our frontal lobes and our higher order cognition. There may be a kind of automatic revulsion. And those are with overt attitude scales. Maybe subconsciously we have even worse attitudes. And so there's ways of trying to detect now through reaction time tests what we really may feel about certain groups, and that evidence is even more damning. At another level, if we're anthropologists for a moment, we might notice that in over half the states of our country today, if you admit to having a mental illness, you don't get your driver's license renewed, you can't vote or run for office or serve on a jury, and you pretty much automatically lose child custody. So this is discrimination. I had a depression some years ago. My father, as you'll hear, had serious bipolar disorder, so I can't vote or run for office. It's a good thing such laws weren't in place. In 1860, Lincoln could have never run for president. The media images of mental illness are still focused far too much on violence. There are rare forms of psychosis that are associated with violent behavior. If you have a paranoid delusion, you may strike out first against others, but with treatment, those rates drop right back to baseline. And what's little announced is that people with serious mental illness are much more likely to be victimized by crime than to actually perpetrate violent crime. So stereotypes get in the way. What are the reasons for this kind of stigma? Well, if we had all morning and I gave a lecture, we could go into detail, but very quickly in headline form, maybe if I confront people who don't seem fully rational or behaving in aberrant or strange ways, that threatens my own sense of self-control and sacrifice. And look, it's hard for me to get up and do webinars and work, and maybe I want to put out of sight, out of mind people who threaten my own stability. Now there's this issue of control going down the slide here. If you're behaving in front of me in a socially deviant way and I think you're faking it or just being kind of weird, well, I'm going to stigmatize you. But on the other hand, if you had an illness, you're having a seizure, I would forgive you and not blame you. So maybe some people have contended the way to really eradicate the stigma of mental illness is to say that people with these conditions have genetically caused biological brain disorders because it takes away the blame. Well, it's true that the blame can be taken away, but too often the perception is also that this individual is pretty hopeless. You can't change genes, and I want to keep a lot of distance from such people. So merely saying that serious mental illness is solely a genetic disease of the brain is probably not the answer to stigma. If we're sociologists for a moment, all societies that we've ever discovered have social hierarchy in them, and people with low status, often including people with mental disorders who don't earn full incomes or get full education, etc., are blamed because, gee, maybe we'd really have to look hard at the structural reasons for the stigma, but it would be better to blame the people for not succeeding. Just moving to the next page quickly, maybe it's just good old classical conditioning like Pavlov and the dogs. If you continue to see associations between mental illness and violence or incompetence, you get conditioned to that stereotype. And the media, I think, is a big issue here. Maybe we've been naturally selected in some ways to be stigmatizing against groups that appear contagious, or people who might cheat us, or people with very different customs or even skin color. So this is the evolutionary view, that some stigmatizing attitudes are actually kind of hardwired right into our brains and minds. Goffman, the sociologist, talked about this well over 50 years ago, and he wasn't evolutionary at all. It makes us think that stigma is going to be somewhat hard to overcome because of how automatic revulsion might be, but we do have frontal lobes and we do have empathy, and stigma can be overcome, which leads to the last point here. Much stigma is promoted by social leaders by dehumanizing. The Jews and people with mental illness are vermin, as Hitler and the fascists said. If you're not fully human, then why should society treat you with any respect? So, of course, the antidote here is to humanize, is to make the full humanity of people with various conditions and illnesses like mental disorders quite salient, and then people's empathy will come into play. 2 final points before I get more personal. It's logical that if I'm a member of a group that receives a lot of social stigma, I know what the campfire stories say. I know what the Twitter posts say and social media. I may internalize. I may blame and stigmatize myself. Now, it used to be thought this was inevitable. Any member of a stigmatized group automatically had very low self-esteem and showed high self-stigma. We know that from the 60s onward. Black Power, gay pride, women's movement. You can be a member of an oppressed group, but if you show solidarity, group identity, and are active, your self-esteem may not suffer at all. But until very recently, this is where the International Bipolar Foundation, this is where the National Alliance on Mental Illness and other advocacy and self-help and support groups come into play. Now you can be a member of a group to advocate for yourself, which is really the cure for self-stigma. Why is internalized or self-stigma important? We're at the bottom of the slide here. If you have a lot of beliefs that are self-stigmatizing, it's very difficult for you to enter treatment, or you probably drop out of treatment before you've completed your course of it. So this is an enemy we need to fight, is to have people's images of themselves not be consistent with the stereotypes. Our final term is courtesy stigma, invented by Irving Goffman, the sociologist at Berkeley, in his book on stigma from 1963. And he said, with tongue fully in cheek, if society bothers to stigmatize a group, it's only common courtesy to stigmatize anybody associated with the members of such a group, like family members. And of course, in the majority of the 20th century, families and parents were explicitly blamed for having caused their child's mental illness. So courtesy stigma in our professional models, the refrigeration theory of autism or the schizophrenic mother theory of schizophrenia, really added to courtesy stigma. And let's not forget, psychiatrists, clinical psychologists, social workers, allied health professionals in the mental health areas are also victims of courtesy stigma, because we work with people who are in a low social status, people with mental disorders. So I think there's a lot of disclosure and a lot of reckoning to be done by professionals to overcome some of their own courtesy stigma, which they may foist upon patients. Do Americans know more about mental illness factually than in the 50s and 60s? Absolutely. Every study shows it. Many more people than back in those days can identify the symptoms of schizophrenia, bipolar disorder, alcoholism, autism, ADHD, PTSD, etc. But at the same time, attitudes have not followed suit with these changes in knowledge. In fact, 3 times more people today automatically think of violence and danger in association with mental illness than in 1955. And social closeness, the desire to be close to somebody with a mental disorder, hasn't really budged since the 50s and 60s. So knowledge is improving, attitudes are not, which is maybe the central issue. It's going to take humanization, it's going to take people telling their stories to bring these issues to light. There may be a lot of reasons for this dissociation between improvements in knowledge and improvements in attitudes and behaviors. We've deinstitutionalized 93% of people who used to live in state mental hospitals, but where are too many of them living now? under the freeways, on city streets in warm weather cities. So many people confront serious mental illness in the form of muttering homeless individuals who often conform to the worst stereotypes. How do you get into a state mental hospital against your will? Well, you're a danger to self, danger to others, gravely disabled. Those are the California reasons. Other states are similar. So there may be an association automatically between danger and mental illness. And again, in some ways, the public face of serious mental disorder is pictures of deranged-looking young men who've shot up schools. These are horrific events, but this is not by far anywhere near even a plurality of people with mental disorders, but the media images need to be overcome. Why would bipolar disorder and individuals who experience bipolar disorder be stigmatized? Well, think of the media, think of popular lore. How can one person in relatively short periods of time be elated and grandiose and then despairing and depressed? It's the Dr. Jekyll and Mr. Hyde, two different personalities lingering in the same skin, the stereotype of the mad genius. People with bipolar disorder are out of control, their emotions are out of check. Remember our first reason a few slides ago, this might be threatening to many social observers. It's also the case that if a person tends to behave in an inconsistent way, think of a kid with ADHD who does well in English in middle school, but then really has a bad relationship with the math teacher, and math isn't the strength, and fidgets and squirms and disrupts the class. Teachers and classmates think, what's the matter with this kid? Seemed really good a period before, now is really out of control. What's the reason for that inconsistency? That kid must not be trying hard enough. People with bipolar disorder in some ways epitomize inconsistency and serious emotion dysregulation as they enter mood episodes. And this inconsistency, the why can't you keep it in check the way I saw you yesterday or last month or last year, is a big trigger of stigma. Interestingly, in a well-noted British study done back a decade or a little bit more ago, parents of a group of kids with pretty serious autism spectrum disorders and another group of parents of kids with what used to be called Asperger's, we today call high-functioning autism, were interviewed about the stigma they and their kids had received. And by far and away, the parents of the kids with so-called high-functioning autism, milder, but smart, weird, why does he, it's often a boy with autism, seem to be doing well in school and then say the wrong thing at the wrong time? In fact, stigma was perceived as much higher with that group than for kids with more serious language delays, often whose classmates really took the kid on and supported him or her. So stigma isn't always associated with severity. It might be the inconsistency and unpredictability. It's also the case, look in any op-ed, look on social media, talk to your friends and neighbors. Everybody gets a diagnosis of ADHD these days if they're a kid. Everybody who's just a little mood dysregulated must get a bipolar disorder diagnosis. So in some ways, the public perception of overdiagnosis and everybody gets a psychiatric label fosters what? Ridicule, or it's not real. I think we need really careful assessments to prevent overdiagnosis, but we of course also need to diagnose people who really need help and care. But I think all of these are reasons why bipolar disorder may receive particular stigma. And what about medication? There's a lot of attitudes about why do you need a medicine to control your moods and behavior? We wouldn't think twice about taking insulin for diabetes or an antibiotic for your bacterial infection, but there's something almost moral about judgments of why would you need a medication to control emotions and an inconsistent or depressed behavior. So we're going to switch gears and talk for a few minutes much more personally about how I became a clinical psychologist and where my interest in stigma emerged. My newest book, just out this past summer, is called Another Kind of Madness. That's me, just after my freshman year of college in the backyard in Ohio with my dad, who just 2 months before had started to break the silence in our family and tell me about his life of very extreme episodes, which had been misdiagnosed as schizophrenia for 40 years. Why would I name a book Another Kind of Madness? That's kind of an old school term for mental disorder, mental illness. Maybe it's even stigmatizing. I found this phrase in a quote from James Baldwin in one of his masterpieces, Giovanni's Room, where Baldwin talked about the madness of forgetting, falsely keeping innocence, the madness of remembering, so you deny your innocence. And in that long sentence, he said, another kind of madness. And when my editor at St. Martin's Press and I were discussing a year ago the title for this book, we brought up this powerful quote from Baldwin, and we both realized that another kind of madness, if you want to call mental illness madness, is stigma and shame. These are worse in their consequences than bipolar disorder or schizophrenia or PTSD or autism or ADHD, because if you're too ashamed to talk about it and you don't get treatment, and we fund the National Cancer Institute at higher levels than the National Institute of Mental Health, that prevents people from getting the care they need. And it can ruin and destroy families and individuals. So another kind of madness is stigma. And the subtitle, of course, is A Journey Through the Stigma and Hope of Mental Illness. So very briefly, my dad was Virgil Hinshaw Jr., born outside of Chicago, 1919, the fourth of four boys. His parents, Quakers and missionaries, big in the Prohibition movement in the United States. My grandfather helped get the 18th Amendment passed. The first big event in Dad's life occurred when he was 3, when his mother died from cancer in a hospital in Chicago. It's fairly well known that if you lose a parent between the ages of 3 and 5, more so than if you lose a parent as an infant or after 5, this is a risk factor for developing serious mood disorders later in life. So there was Dad's first vulnerability. His father, my grandfather, moved the 4 boys out to California, to Southern California, to Pasadena. He remarried, another missionary. 2 more boys joined the family. My step-grandmother singled my father out as the youngest of the 4 original boys for very harsh ritualistic physical punishment. So Dad had now another risk factor of physical abuse, loss of mother, physical abuse, and obviously the genetic loading he carried for serious mood disorder was in some ways a kind of triple whammy for him. Here's a photograph from 1923 in an international prohibition newsletter called The Motherless Hinshaw Boys. Over to the right of the wagon is my Uncle Harold, subsequently developed alcoholism, a big stigma in the home of prohibitionists. Now moving left in the wagon, my Uncle Randall, an economist, very kind to my dad. My Uncle Bob, just 5 in this picture, became a psychiatrist and a psychologist. He witnessed my father's first suicide attempt when Dad was 16. And then at age 3 years and 3 months, little Virgil Jr., my dad, who cried all night, many nights, wishing his mother would return, as his father wrote in letters to relatives. This is a very religious and academic and athletic family. In the 30s in Pasadena, my dad became preoccupied at age 16 with the growing Nazi fascist threat. Visitors to the family home from overseas, big in the Prohibition movement, had told the family that America was doing nothing to heed the signs. In September of 1936, Dad escalated pretty quickly through what was, in hindsight, a clear manic episode, misdiagnosed as schizophrenia back then. Couldn't sleep, wandered the streets, became up with the belief that he could fly. So now his hypomania had turned into full-blown mania, and that if he lifted his arms and flew at sunrise, the world's leaders would take heed and fight the fascists. Dad stayed up all night, wandering the streets of Pasadena, climbed the roof to the roof of the family home, made his first flight, crashed to the pavement below, broke his wrist, was bleeding from the head, survived the fall, the crash, ended up at LA County Hospital with a diagnosis of schizophrenia, and was shipped off to Norwalk County Hospital, still around with a different name in Southern California, for 6 months. An adult unit, no school. The only treatment was being chained to his bed at night to prevent wandering. During the fall, 2 months later, my grandfather was called urgently by the hospital superintendent. His son, my dad, Virgil Jr., a football player and shot putter, had gone into the hospital at 180 pounds, believed that the food was poisoned, now weighed 117, and the minister was called in that night to deliver last rites. Somehow the voices and the delusions cleared. Several months later, Dad was released the following early spring, but the family didn't want to talk about or jinx his recovery. No one knew, other than this vague term of schizophrenia, what had happened. So the family remained silent as Dad got back to high school, earned all A's, was awarded a scholarship subsequently to Stanford, and then to Princeton, where instead of going overseas to fight in World War II, conscientious objector because of the Quaker family, but also a 4F for having been 6 months in a public mental hospital. At Princeton, with top grades, he studied with Bertrand Russell for a full year when Russell was on sabbatical from England. He got to know Albert Einstein and wrote a chapter on Einstein's social and moral philosophy. So a brilliant academic career, but just as his dissertation was being completed, he thought he could predict the end of World War II by telepathy, started raging, became paranoid, was shipped off this time to Philadelphia State Hospital, Philadelphia being one of the major cities not too far from Princeton, the facility called Byberry for the district outside of Philadelphia in which it was housed. He believed while there that in a delusional fashion he was being held in a concentration camp in Germany. One of his brothers, Randall the economist, would visit him every Sunday. Took him on a day pass, got him out in the car a few months into his stay, but Dad shouted and translated the road signs into German, believing they were escaping a concentration camp in Germany. Now, you can say, and I did for many years once I heard this, that his mania had increased and he was psychotic and delusional again, but then 10 years ago I read the exposés of Byberry, known as the worst mental hospital in the U.S., 7,000 men crammed into space for 1,400 in one of the men's dorms, regular beatings and deaths. And all of a sudden I began to think that there was a metaphorical truth to the delusion of being held in a concentration camp. The snake pits that used to serve as our mental hospitals were terribly inhumane. Before starting Stanford and Princeton, there's Dad as valedictorian of Pasadena Junior College, having recovered in between some of his episodes. Dad got out of Byberry 6 months later with another miraculous, spontaneous recovery. Got a job at Ohio State as an assistant professor of philosophy. Met my mother there, a grad student in history. He was back in Southern California for a family reunion in the late 40s. Here's the 6 boys. My Uncle Harold, who ended up dying of alcoholism, on the left. My Uncle Randall, the kind economist who visited Dad at Byberry. Uncle Bob, the first one out of the house in 1936 to witness my dad's jump from the roof. Became a psychiatrist and a psychologist, inspired to help fight mental disorder. There's my dad, obviously regained all his weight, looking very robust in his t-shirt. And then the 2 half-brothers, Paul and Harvey, both of whom were very musical, and both of whose firstborn sons developed respectively schizoaffective disorder and chronic schizophrenia. So we see substance and mood disorders over on the left side of the photo, and schizophrenia spectrum disorders represented by my step-grandmother over on the right side of the photo. All through the 50s and 60s when I was growing up, Mom got to know of Dad's condition when she became pregnant with me and my sister, both triggering major manias in Dad. Many hospitalizations, lots of unnecessary medication, which had now come out in the 50s, lots of unnecessary electroshock therapies, which were used more punitively than not in the 50s. Dad wondered what to tell my sister and me when he'd returned from 3 or 6 or 12 months mysteriously gone. And the lead doctor said, if your children ever learn of your schizophrenia, your serious mental illness, they'll be permanently destroyed. You're never allowed, and your wife is never allowed to mention it. So we had doctor-enforced silence. It was an idyllic childhood in many ways for me. Growing up in Ohio, we even had 50-yard line seats at Ohio Stadium to watch the beloved Buckeyes play football. But there was also a terror in the house, this silent mystery of why Dad would vanish. I thought he was probably dead. No one was allowed to talk about it. He'd return one day mysteriously with no announcement. What do kids do when something's going wrong in a household, but nobody talks about it? Well, you've got a choice. You can believe the world's a random, awful place, or you could blame yourself, internalize, because at least you've got some control. So I was a big internalizer. Maybe if I'd been a better son, Dad wouldn't have vanished. And if I don't ask any questions, he'll come back sooner. Here, during the late 50s, we're in Florida. Dad's well during the spring. We're spring break down in southern Florida playing shuffleboard. Many great memories, but also some memories of mystery and terror and silence. When did I learn of what I'm telling you about and have written about in Another Kind of Madness? Not until I went off back east to college and came back for my first spring break. Back in high school, I played sports, studied hard, kept my distance from the family. I knew something was terribly wrong, but not what. My parents were masters at hiding the episodes from me. But Dad pulled me aside my first spring break from college, freshman year, and said, son, perhaps you should learn something of my life. So finally, I learned of being in Norwalk Hospital in the 30s and Byberry, and then Columbus State and many California facilities. His brother Bob would fly out to take him to facilities. All those years of silence and shame as a child. One time in first grade, Dad was gone for a summer, and I wandered through the house and had this kind of funny vision of balloons near the ceiling. And then I had the sense that the balloons were filled with poison gas. I don't know if this was a kind of hallucination or just a vision, but it was very symbolic. The stigma and shame and silence were those molecules of poison gas inside those airtight skins of the balloons. Once Dad came out of the closet and disclosed to me, I changed my major to psychology, decided to be a clinical psychologist and researcher and professor. But for many years, until I overcame the silence and shame inside myself, I was terrified that I would develop schizophrenia, Dad's alleged illness, because it runs in families through genes, and I would end up in mental hospitals. It took me years to overcome the stigma myself and begin to tell close friends, girlfriends, mental health professionals, therapists. And today, as you can hear, I make it a point, beyond the science I do about child and adolescent mental health, to tell our family story. Dad kept many journals. I didn't know of these until many years into our regular talks we had whenever I was back home. I helped diagnose him correctly with bipolar disorder right out of college. He finally got on lithium and had some symptoms for years. But deep inside, his self-image was that he was quite flawed, because being placed in a brutal mental facility at age 16, I think, really helped shape his identity. He told me once in his latter years that he wished all his life he'd had cancer. And I thought to myself, and even said to Dad, well, what do you mean? I started to worry that maybe he was getting symptomatic again. He said, son, don't you understand? Cancer's a real illness. All my life I've apparently had schizophrenia, and now you've said I've had bipolar disorder. But those aren't real illnesses. Those are mental illnesses. Think what that term means to a philosopher. Maybe I've just imagined how I've longed for a real illness for all those years I spent in hospitals. This hit me like a ton of bricks. Your identity forms as a kid and teen, and unless we have really humane evidence-based treatment, all the book learning in the world later on for somebody as smart as my philosopher dad didn't fundamentally change his self-image. Two more photos. Here I am right after my PhD from UCLA. In the early 80s, I still had my mustache then. My wife told me later when I met her that the 70s had ended a long time ago, so I shaved my mustache. And here's Dad, mid-60s, a little bit of a punch from the lithium, full head of dark hair. I have gray hair, not everything's genetic, but he's looking very robust. And here is just 5 years later, excuse me, up in Northern California, Stinson Beach, my first faculty appointment at Berkeley. And as you can see, if you look closely, Dad is stooped. He's lost 25 pounds, and he began the Parkinson-like illness that ended up, in many ways, taking the last years of his life. All of the wrong medications and all of the electroconvulsive therapies, if only he'd been diagnosed correctly, he might not have had, I think took a toll. We know that ECT, electroconvulsive therapy, is a very effective treatment for serious treatment refractory depression, medication refractory depression, but back in the 50s it was often used more indiscriminately and punitively. Here's 5 bullet points. We know that mental disorders, including bipolar disorder in particular, have a huge impact, but there's still too much shame. Accurate diagnoses, responsive treatments are crucial. I just mentioned point 3 about Dad's wishing he had a real illness. Very poignant to hear that. Dad, in many ways, was resilient. My mother was the hero of the family, the unsung hero all those years. But when Dad was well, he really helped take emotional care of me. He had a career in philosophy. Thank goodness for the tenure system. He probably wouldn't have made it through without getting fired many other jobs. Number 5, very briefly, our colleague Bill Beardsley, former chief of child psychiatry at Boston Children's Hospital, professor at Harvard Medical School, has devised a form of family therapy for families in which one or both parents have either depression or bipolar disorder. Now, those parents need individual medication and treatment. This therapy doesn't replace that. But in this 16-week family therapy, the therapist works with the parents and then brings the kids in later to talk to the kids about mom's drinking or dad's absences or the time the police had to come or the time off work in child language, what's going on in the family because of the unipolar or bipolar depression, to prevent the kids internalizing. Families resist doing this. It's too shameful. I don't want to tell my kid about my depression or bipolar disorder. In 2 very controlled studies, at the end of 16 weeks, kids in families receiving Beardsley's form of family therapy, family talk therapy, do better academically and socially and have a higher self-image. 4 years later, with no further treatment, their own risk of developing serious depression is cut by 50%. Yes, bipolar disorder to a high extent and depression to a moderate extent are transmitted genetically from parent to child, but part of the other transmission is stigma and shame and silence. If nobody talks about it, the kids internalize and blame themselves. So we know that genes and environments go together in triggering serious mood disorders, and we know that biological treatments, medicines, psychotherapy for the individual, and this family communication therapy are going to prevent, we hope, much of the next generation's risk. If we had more time, I'd tell you about our program called Let's Erase the Stigma, now run by Bring Change to Mind up here in the Bay Area in San Francisco, where we get high school kids to join clubs, not mental health groups, but clubs. These clubs are active, open, empathy, social action clubs. Kids learn a little bit about mental illness, but they really improve their attitudes and social distance even more. I think we're going to change society's attitudes through young people, just the way that attitudes toward gay marriage have really improved in the last 15 years, mainly through young people. Here's the final slide about the International Bipolar Foundation. Please read it. This is one of those support, self-help, and advocacy groups that haven't been around for a century. They've been around for a couple of decades on average, but they're the antidote towards internalized stigma. I have no disclosures to report in making this webinar talk except for the royalties I received from the Mark of Shame and another kind of madness. I really appreciate your attention, and I'd be glad to answer any questions.
Thank you very much, Professor Hinshaw. That was a wonderful presentation. Now we're going to start the question and answer portion. While you guys are submitting your questions, just a reminder that this webinar is being recorded and will be archived on our website for future reference. All right, it doesn't appear there's any questions at the moment, so I will ask a question.
Sure.
Professor Hinshaw, could you elaborate a little more on the program you were just talking about, the Let's Erase the Stigma?
So some years ago in Los Angeles, a fellow named Philippe Fontalea thought that he really had the answer to stopping mental illness stigma. And he came up to Berkeley and met with me, and I thought, boy, I'm glad you got the idea because I'm thinking about it a lot. And he said, I think it's really teenagers who will make the difference in attitudes. And they need a place where their natural empathy and social activism can take hold. Now, some kids need support, therapy. But he said, this would be a school club, just like the chess club or the rugby club or the Latin club. It would be the Let's Club, the Let's Erase the Stigma Club, with not a professional, but a teacher as the advisor. And there wouldn't be a rigid curriculum of learning the facts about schizophrenia and bipolar disorder and ADHD, but it would be for a chance for kids to come up with ways to raise money and ways to lobby the school board and talk to their classmates and city councils about discrimination and prejudice and stigma in their communities. Sort of a self-led group exploration and social activism experiment. We did a study, I just showed you the slide of it. These kids didn't dramatically gain in knowledge. In fact, other programs that teach kids facts about mental health, kids learn more about mental health and they become more stigmatizing. Because what's learned is, oh, people with schizophrenia hear voices, that's scary. People with depression become suicidal, how selfish. What's needed is speakers, real life examples, the kind of knowledge that breaks the stereotypes that people with mental health issues can and do recover, lead wonderful and productive lives. So this program was taken over a couple of years ago by Bring Change to Mind, Glenn Close's anti-stigma organization, on which I serve as a voluntary scientific advisor. And Bring Change to Mind up here in the Bay Area has been enacting these clubs. We did a trial in 50 high schools last year, and the clubs are now in 100 Northern California high schools. We still find evidence that joining these clubs and participating in this empathy and social activism helps reduce social distance and gets kids engaged in activities to reduce stigma. So we think that there's hope for the future because young people are the fulcrum points for changing society's attitudes and practices generations down the road.
Absolutely, and well, thank you very much for that answer, Professor Hinshaw. It looks like we're still waiting for some questions to roll in. Oh, I see a question. All right. The next question is, how do we help medical professionals to treat the total person? Mental health patients need education on physical fitness, nutrition, medication, counseling, the importance of sleep, etc. So I guess the question is, how do we help medical professionals to treat the total person?
I wish I'd written that question myself so I could answer it. I think this is a wonderful question and it's really needed. So, back in the 30s, and 40s with Dad's initial hospital stays, we didn't have psychotropic medications at all, and the mental hospitals, the state facilities that had been formed a century or more before that, had turned too often into large snake pits. Much of the idea back then was that if you could get expensive individual long-term psychotherapy, that was the only cure for bipolar disorder or serious mental illness. Then in the 50s and 60s and in the decades since, antipsychotic medications, mood stabilizing medications have really come to the fore. Many clinical trials show that they're not cures, but they really can help recovery. But the profession of psychiatry has changed pretty drastically, so that most psychiatrists dispense medications but aren't really fully trained in psychotherapy and treating the whole person, as the very perceptive question alluded to. So I believe, if I could be czar for just a day, people please appoint me, we would get mental health teams. Psychiatrists would be in practice with clinical psychologists and social workers and OTs and everybody else, so that while the medication-related needs are attended to, group support is very helpful for people with bipolar disorder. Because it's hard for many people with bipolar disorder to be motivated to stay on medication. People miss the hypomanias, and side effects can be problematic sometimes until doses get adjusted. Sleep, social rhythm therapy devised by Ellen Frank, regular patterns, sleep and exercise, very important to recovery. Family education, removing the shame and stigma from family members. Coaching and how to disclose to your employer that you've got a mental illness. I think we have to be open. I don't know that you disclose every time. First time, maybe you get the job first, and then you can use the Americans with Disabilities Act to make sure that you stay in your job if there's discrimination. But I think it's going to take multiple disciplines in a team approach to realize that, as essential in many, if not most cases, medication treatment is, particularly for bipolar disorder, the whole person, exercise, sleep, individual group therapy, getting support is really necessary to promote full recovery. So thanks for that great question.
Thank you for that great answer. The next question is, I do domestic violence victims assistance for our local safe house at the DA's office. I have noticed a running trend. A large portion of our domestic violent victims have mental health issues such as bipolar disorder and stay with their abusers because the abuser is their support system. This community seems to carry the attitude that counseling is weak. They decline counseling even when my agency offers to pay for it. Do you have any suggestions on helping both the individuals in the community with this mindset?
Boy, this is a very tough question. I wish I had a great answer to this, but let me comment a little bit. Domestic violence, domestic abuse is a really tough dynamic, and it's aided and abetted in its negative consequences, of course, if the victim, the survivor, carries, as we found in our own research, a long history of ADHD that predicts high rates of intimate partner violence, or has a mood disorder like bipolar disorder. And the dynamic that's formed is, maybe I've deserved it, maybe I wasn't fully a good partner in the relationship, and I still need my abusive partner, and you get this push-pull of trust dynamics that are warped. And the other part of the question is, maybe because of self-stigma, I'm not motivated to get the individual attention and care I need that might provide me with the strength to get out of this abusive relationship. So I think we need in high schools much better education about domestic violence. I think we need support around treatment of mood disorders and other disorders that, again, involves more than medication. It treats the whole person. And we get into the situation where, just to bring in another issue, once you're 18 and above, let's say you're having a pretty serious psychotic, depressive, or manic episode, you may lose insight into the nature of your illness, but we can't force treatment unless it's, again, really extreme, danger to self, danger to others, or grave disability. And we can't really make a person escape an abusive relationship, but anything you can to encourage the person, despite the self-stigma and despite the shame of admitting you need help and therapy, might provide some strength and then some support around escaping an abusive relationship, which will probably worsen with time as the power dynamics go south.
Got it. Thank you for that answer. The final question today, what are your thoughts on individuals disclosing a mental illness to their employer or other people in their lives? And do you have any suggestions on how to do this?
Yeah, I'd alluded to this very important question a moment or two ago in an earlier answer. So, as you can hear from my talk in this webinar and everything I do, we can't have the default position be shame and silence and nobody can talk about it. Remember, is it this Sunday coming up or a week from Sunday, the big NFL guys are going to be wearing pink knee socks in support of breast cancer because women have talked about cancer. It's now a national issue. So we have to disclose and talk about it, point one. But point two, I'm not advocating that you wear a sandwich board around you saying that you have bipolar disorder or you tell everybody you meet. Disclosure is a matter of timing and confidence and practice. Do you disclose your illness in that job interview? Well, you don't have any protection. You don't have the job yet. Maybe you get the job, and then if it's a big company, is there an HR firm? And if you read up on the ADA, the Americans with Disabilities Act, it's illegal to discriminate in public or in the workplace against people with medical and physical disabilities. So what I'm doing sort of long-windedly is saying timing. Practice your disclosure. Get support. Don't feel you can't disclose, but don't feel compelled to disclose to everybody from the first minute onwards. Practice, rehearse, get support around it, and then I think people can feel empowered to disclose when they want to strategically, and the more people do, the more society will realize mental illness isn't rare, it's everywhere.
Wonderful. Well, thank you so much, Professor Hinshaw, for sharing that answer and also for sharing your expertise with us today. We're going to go ahead and close up the Q&A portion. Thank you, everyone, for joining us today, and we will see you at our next webinar. Thank you.
Thank you so much. Bye.
Bye-bye.